Welcome to Grand Rounds. My name is Rebecca Muley, and I'm one of the Grand Rounds co-directors, along with Drs. Adi Talati and Alex Harris. Next week's Grand Rounds will be the Welsh Memorial Neuroscience Lecture given by Professor Aaron Schumann from the Max Planck Institute for Brain Research in Germany, giving a talk entitled, How Do Brain Synapses Get the Proteins They Need? Before we introduce today's speaker, a reminder that if you are participating via Zoom, please post questions using the Q&A feature, not the chat. I'm joined today online by Dr. Alex Harris, who will forward any online questions to me. So I will be the reader and the Q&A moderator in the audience here, and so all questions will flow through me. We encourage trainees to answer a question, and we'll hold space for trainee questions both in person and online. Online, please indicate if you're a trainee by putting big letters trainee in the front of your question. Also, remember to fill out your CME surveys after the talk if you'd like CME credit for today's lecture. There's a QR code on the table outside for those in person, and the link will be posted in the chat on Zoom at 12:15 p.m. And now it's my pleasure to introduce today's speaker, Dr. Marc Potenza. Dr. Potenza is the Stephen M. Southwick Professor of Psychiatry in the Child Study Center and of Neuroscience at Yale School of Medicine, and he directs the Division on Addictions, the Center of Excellence in Gambling Research, the Women and Addictive Disorders Core of Women's Health Research at Yale, and Yale Research Program on Impulsivity and Impulse Control Disorders. He is a board-certified psychiatrist with subspecialty training in addiction psychiatry, and his research focuses on the neurobiology and treatment of addictions and other disorders characterized by impaired impulse control and reward-related motivations. Dr. Potenza's research has applied neuroimaging, genetic, epidemiological, and clinical trials methodologies. He's mentored over 300 scholars in clinical research and neuroscience, and he co-directs training programs focusing on addiction treatment development research at Yale and alcohol use, stress, and psychopathology in Thailand. He has published over 1,000 papers and chapters and is ranked first globally by the independent firm Expertscape in multiple clinical research categories, including gambling and addictive, impulsive, and compulsive behaviors. So we are so pleased to invite you here, Dr. Potenza, and the title of his talk today is Do Existing Models of Behavioral Addictions Fit with Those of Substance Use Disorders? Please join me in giving him a warm welcome.
Thank you very much for the kind introduction. Thank you for having me give grand rounds. My apologies for doing this virtually. I think it's worked out for the better since I have a head cold presently and I'm trying to isolate myself so that I do not give it to other people. So without further delay, I will move into the talk. I have a listing of disclosures with respect to pharmaceutical, gambling, and other entities. And the learning objectives for today's talk include describing the current theoretical models of addictions, describing which disorders constitute addictive disorders in the most recent versions of the Diagnostic and Statistical Manual and International Classification of Diseases, and then to describe how to assess for and treat behavioral addictions, including especially those involving the internet. So if we think about the word addiction, it's derived from a Latin word meaning bound to or enslaved by, and in its original formulation was not linked to substance use. However, going back several hundred years, it became linked to excessive and interfering patterns of alcohol use. Later, other substance use such as opioids and cocaine. And by the 1980s, the DSM the DSM substance use work group felt that unanimously that addiction could be defined as compulsive drug use. However, in the 1990s, people suggested that the core features of addiction may extend beyond substance. If we think about those as being impaired control, compulsive engagement, an appetitive urge or craving state prior to the engagement in the behavior, and continuation of the behavior despite adverse consequences, then perhaps the term addiction could be applied to a broader range of behaviors. And this trend, this notion was reflected in a couple of articles from Constance Holden in the journal Science in the first decade of this millennium. In 2001, she asked whether behavioral addictions existed and whether we could use new approaches like brain imaging to look at similarities between um, non-drug behaviors like gambling and substance use behaviors like cocaine use to look for how reward circuitry and other processes may be linked to these uh, related conditions. And then in 2010, she authored the article Behavioral Addictions Debut and Proposed DSM-5, where she highlighted some of our data, and this heralded the reclassification of gambling disorder together with substance use disorders in the DSM-5. So the DSM-5, which was released in 2013, has been updated recently with the TR version, and the ICD, the International Classification of Diseases, had its 11th revision released earlier this decade, in 2018, and adopted in 2019. Uh, so these are the two main nomenclature systems for psychiatric disorders, as well as the ICD-11 or the ICD-10, which is currently in use in the United States for physical health disorders as well. So if we think about how gambling disorder has been considered in the Diagnostic and Statistical Manual. It was initially included in 1980 in DSM-3 and underwent revisions in DSM-3R and DSM-4. The term that defined the disorder was pathological gambling. This was later replaced with the more neutral term gambling disorder to try to limit any potential stigma related to the condition, as it's currently estimated that perhaps 10% or less of individuals with gambling disorder ever seek formal treatment or self-help for their condition. Uh, there are other changes going from DSM-4 to DSM-5. These over time, the criteria have changed, and the thresholding is different. For example, currently it is 4 of 9 inclusionary criteria for making a diagnosis, and this is more stringent than the 2 of 11 for making a substance use disorder, which may lead to differences in the public perception of the health consequences of the disorders. Now, importantly, with respect to gambling behaviors, we have seen a rise in online sports gambling. The Supreme Court overturned the Professional and Amateur Sports Protection Act in 2018, which allowed states on a one-to-one basis to consider legalizing online sports gambling. And what we can see is that since that time, and this is a map as of May 2024, 38 states and the District of Columbia had legalized sports gambling. And in this setting, there's not only been the legalization and the increased social acceptance, I would argue, given the sporting culture in the United States, as in other societies, particularly for young males, um, we see that more people are gambling online. There's been increased media coverage with shows like ESPN showing betting lines and having programming that is focused on sports gambling. And we have seen substantial advertising to the tune of over $400 million per year being spent on television ads in the United States. So that it's difficult now to watch a sporting event on television without seeing advertisements for online sports gambling. with sports celebrities and movie stars often promoting such gambling. And then importantly, there is the internet access, which precludes individuals from going to casinos or going to find a bookie to place a bet. And with mobile apps, one can place a bet on about anything at any time, anywhere. So in this setting, we've seen an increase in calls for help for gambling problems. In the year that Connecticut legalized online sports gambling, we saw approximately a 90% increase in calls to our gambling helpline, with this increase being apparently driven by young males with online sports gambling problems. Now, historically, data have suggested that there are high rates of co-occurrence between gambling and substance use disorders, similarities in the clinical courses with adolescents and young adults or emerging adults, showing high rates of high prevalence estimates of these conditions. There have also been sex-related differences where telescoping phenomena have been initially reported in alcohol use disorder, later in drug use disorder, and more recently in gambling disorder. And this telescoping phenomenon is that although females, as compared to males, begin to engage in the behavior later in life, the time frame between initiation and developing a problem is foreshortened or telescoped in females as compared to males. And this has been seen with gambling disorder going back now about 20, 25 years from multiple jurisdictions. Then there are similarities in the clinical characteristics, some of which are reflected in the diagnostic criteria, including aspects of tolerance, withdrawal, interference in major areas of life functioning, and repeated unsuccessful attempts to cut back or quit. There are some of the clinical characteristics are not equally reflected in the diagnostic criteria for the different disorders. For example, craving criterion was added for substance use disorders, and gambling urges or cravings are, I would argue, similarly relevant for gambling disorder. And then there are similarities in the biologies that may underlie some of the similarities in treatments, be they behavioral interventions, pharmacological, or other. So there are different competing theories with respect to how biology may relate to behavior. The DSM approach has been more categorical with specific disorders that may be heterogeneous in nature. Some people, like Tom Insel, have proposed that using a research domain criteria approach may link biological factors more closely to transdiagnostic constructs. And preliminary data suggests that both of these approaches have utility. So some of the transdiagnostic factors that have been investigated do fit with RDoC criteria like the positive valence system and the negative valence system. Um, and then more broadly, measures like impulsivity and compulsivity, as well as other factors, may relate across diagnoses of gambling disorder and substance use disorders in relevant ways. So if we think about the definitions for some of these constructs, going back about 25 years, Jerry Muller and colleagues defined impulsivity as a predisposition toward rapid, unplanned reactions to internal or external stimuli with diminished regard to the negative consequences of these reactions to the impulsive individual or to others. And if we think about this as a definition for impulsivity, it applies to many psychiatric groups, not only gambling and substance use disorders, but also bipolar disorder, attention deficit hyperactivity disorder, among others. And if we think about this definition, it's a multifaceted, complex construct. And when people have done factor analyses, two or more domains have been repeatedly identified, including choice and response impulsivity that may be assessed in different manners. So we were interested in understanding the extent to which some of the diagnostic measures versus the transdiagnostic measures related to biological constructs. So in this study, we looked at individuals with gambling disorder, cocaine use disorder, and healthy control subjects, and looked at gray matter volume. And we also looked at how gray matter volume related to impulsivity across the diagnostic constructs. And what we found was that there was a main effective diagnostic group where the individuals with cocaine use disorder showed lower gray matter volumes in frontal cortical regions extending from ventral to dorsal, frontal, medial, frontal, cortical brain regions. Uh, Whereas even though the groups of individuals with gambling disorder and cocaine use disorder tended to score more highly on measures of impulsivity, as can be seen by the scatter plot, there was an inverse relationship between um, gray matter volume and impulsivity that identified largely subcortical brain regions as well as the insula. So regions like the amygdala and hippocampus. So it suggests that um, both impulsivity and the diagnostic groupings employed by the Diagnostic and Statistical Manual have relevant associations with the biological construct of gray matter volume, but do so in different manners. So another transdiagnostic element that's been proposed as an endophenotype is compulsivity, which a group of us defined as a tendency to perform repetitive and functionally impairing overt or covert behaviors without apparent adaptive function, performed in a habitual or stereotype fashion, according to rigid rules or as a means of avoiding perceived negative consequences. And again, like with impulsivity, this is a complex construct that may have multiple factors, and it also is relevant to a broad range of psychiatric concerns, including obsessive compulsive disorder, substance use disorders, and impulse control disorders. So, like with impulsivity, we were interested in understanding how measures of compulsivity related to clinically relevant measures. And so we incorporated impulsivity and compulsivity measures into a randomized clinical trial of paroxetine versus placebo for the treatment of people with gambling disorder. And what we found was that at treatment onset, problem gambling severity measures correlated with self-reported measures of impulsivity and compulsivity. Um, but changes in problem gambling severity with treatment, and this is across both the active and placebo groups. This is a study in which there was no main effect of active versus placebo drug. What we found was that changes in problem gambling severity correlated with changes in impulsivity, but not with changes in compulsivity. So if we take a step back and think about some of the models that have been proposed for addictions, there have been dual process models that suggest that there is impaired control over strong motivational drive that leads to engagement in addictive behaviors. There's been a reward deficiency syndrome model that Ken Blum and colleagues have proposed that suggests that um, Individuals with addictions or at increased risk for addictions may not respond at a brain level to um, uh, non-addiction rewards as robustly as people who are less prone to addictions or without addictions. And then an incentive sensitization model that proposes that at early stages, liking and wanting are correlated, but over time they become dissociated such that wanting overtakes the liking in the addiction process. And then there are models that incorporate multiple aspects of these proposed elements, including the impaired response inhibition and salience attribution, or RISA model that Rita Goldstein and Nora Volkoff have proposed. And then there are habit formation models that Barry Everett and Trevor Robbins have proposed that as addictions progress, there may be a shift from impulsivity to compulsivity or more habitual be engagement in the behavior. And some of the more robust data that are consistent across studies, as reflected in a meta-analysis, are shown here. These are data that resonate with the reward deficiency model of addiction, where individuals with substance use disorder or gambling disorder during the anticipatory phase of monetary reward processing show relatively blunted activation of the ventral striatum, consistent with the notion that the ventral striatum, as a key reward processing region, is showing less activation in individuals either with substance use or gambling disorders. We also see in a separate study led by Guangheng Dong that individuals with internet gaming disorder show a blunted ventral striatal activation during a performance of a different reward processing task, suggesting that this might apply to gaming behaviors as well. Now, there is also the idea that with treatment, perhaps we can target some of these associated brain features in people with addictions. And this schematic shows treatment-related brain changes in during performance of the monetary incentive delay task in adolescents with tobacco use disorder trying to quit smoking. And what we found was that during performance of the monetary incentive delay task, at post-treatment as compared to pre-treatment, there was a more robust response in the ventral striatum in a region that had been linked in an independent study of monetary incentive task data to the anticipatory phase of reward processing. So it suggests that this mechanism to make non-addiction related rewards more robust may be helpful for people with addictions, as we also saw this in people with cocaine use disorder. Now, in anticipation of DSM-5, there was debate regarding which disorders might constitute, which behaviors might constitute new clinical diagnoses in the DSM. And Time Magazine had an article in the year preceding the DSM-5 release asking what counts as crazy and what is the new abnormal. And here, binge eating, internet addiction, and sex addiction were highlighted, and all three of these behaviors could conceivably fit within an addiction framework. And so I'll focus on internet addiction. And when the DSM-5 um, substance use committee met, they tackled the idea of whether the internet could be the basis of an addiction. The group felt that the internet was more of a delivery device, like a needle and syringe might be for intravenous drug use, and that the behavior should be the focus of the condition. And so at the time, there had been reports of people dying in internet cafes in Asia from online gaming marathons, not taking care of their bodily needs. There had also been reports of children dying in cars after having been left while their parents went to play video games. It was felt that the most data existed for video gaming, particularly massively multiple online games. And criteria for internet gaming disorder were placed in Section 3 of the DSM-5, the section for further research, but not for clinical diagnoses. We at the time were also interested in trying to understand the extent to which problematic internet use or problematic gaming might be similar to or distinct from substance use disorders and what the neural correlates of these behaviors were. And in adolescence, we found that those with at-risk or problematic use of the internet versus those without showed blunted reward-related responses during EEG. Again, consistent with a reward deficiency model of addictive disorders. Consistent with a dual process model, we investigated cognitive control. And here we looked at individuals with and without internet gaming disorder. We looked at functional connectivity in executive control regions. And we found that there was decreased connectivity in individuals with internet gaming disorder as compared to those without, and that the degree of functional connectivity was related to Stroop out of the magnet Stroop performance, where it was suggested that the decreased connectivity within this network was linked to poorer cognitive control. Also resonating with dual process models of addiction, we conducted a meta-analysis of gray matter volume studies of individuals with internet gaming disorder. And on the left, it shows that the individuals with, as compared to those without internet gaming disorder, showed relatively decreased gray matter volume in specific brain regions, including the ventral medial prefrontal cortex or orbital frontal cortex, and the anterior cingulate gyrus. And these are brain regions that in the nidus schematic on the right have been linked to motivational drive and inhibitory control. So based on these and other data, we proposed a model of internet gaming disorder that had different domains that could potentially be targeted by specific therapies as a way of promoting research into this area. And so far of research that has been conducted for pharmacotherapies for internet gaming disorder, there have been several studies, but not extensive to the extent that there are currently no um, medications that have regulatory approved indications for internet gaming disorder. There have been some randomized clinical trials that suggest that bupropion and escitalopram may each improve internet gaming disorder, and they may also have effects on mood, like symptoms of major depression, as well as impulsivity and inattention, features of ADHD that often co-occurs with internet gaming disorder. However, probably the data that have the most empirical support in the treatment for um, internet gaming disorder come from behavioral therapies like this study that Klaus Wolfling and colleagues conducted in Germany, where they used a cognitive behavioral therapy approach to treat people with internet and computer gaming addictions. So, when the ICD-11 was being considered, there were questions as to the extent to which the ICD-11 would harmonize with the DSM-5 with respect to gambling and gaming disorders. Additionally, there are questions about hypersexual disorder, which was tested in a field trial for DSM-5. And despite the recommendations of the sex and gender identity work group, um, hypersexual disorder was not included either in Section 2 or Section 3 of the DSM-5. So going back now over a decade, a group of us began meeting in conjunction with the World Health Organization to discuss how internet use might be the basis of psychiatric conditions, particularly behavioral addictions. There were debates in the scientific literature with some groups feeling that it was premature to include a gaming disorder in the ICD-11, and others of us uh, describing our thoughts as to why it was important for diagnosis, management, and prevention efforts. In the lay media, there was also debate on back-to-back days in 2018. The Times had articles on game addict disorder is a moral panic versus the National Health Services to open an addiction clinic for young online gamers. And when it was proposed that the ICD-11 may include gaming disorder, the gaming industry came out against this, saying that the evidence for the inclusion of gaming disorder in the ICD-11 remains highly contested and inconclusive, and that they hope that the World Health Organization would reconsider the mounting evidence put before them before proposing inclusion of gaming disorder in the final version of the ICD-11. We wrote back, a group of us, asking whether this was a corporate strategy to disregard harm and deflect social responsibility, keeping in mind that it was about 30 years ago that the executives of tobacco corporations went in front of Congress to testify that they did not think that tobacco was an addictive product. Now, this debate about gaming disorder was not isolated to gaming disorder. There were similar debates regarding compulsive sexual behaviors and how it might be considered in the ICD-11. And a group of us reviewed the literature regarding the behavioral neuroscience data and suggested that uh, compulsive sexual behavior disorder may be better suited to be classified as a behavioral addiction rather than as an impulse control disorder. So, what happened when the World Health Assembly met and adopted ICD-11 in May of 2019? Gambling and gaming disorders were included as disorders due to addictive behaviors. Hazardous gambling and hazardous gaming were also included, and this is akin to hazardous or harmful alcohol use, which has been very helpful in terms of promoting public health, given that there's a larger portion of the population that engages in sub-disordered levels of engagement. Um, and thus the potential harm may be at a societal level greater for that group than for the smaller group with disordered engagement. And then compulsive sexual behavior disorder was included, but not as a disorder due to addictive behaviors, but rather as an impulse control disorder. And the main elements of the disorder for gambling and gaming disorder is described here, and these are the specific criteria for gaming disorder. Three main elements include impaired control over gaming, increasing precedence given to gaming, and continuation or escalation of gaming despite negative consequences. There also has to be significant impairment in one or more domains, and a time frame of at least 12 months is specified with flexibility that if all diagnostic requirements are met and symptoms are severe, then one can make a diagnosis in a shorter time frame. Now, at the time of the ICD-11 being considered, I contributed a case report of sorts in the public domain where a nurse's aide was reported to have been playing video games while a veteran died at a VA hospital in support of the idea of considering the inclusion of hazardous gaming and gaming disorder. So hazardous gaming and gaming disorder are mutually exclusive. There are defined features for hazardous gaming, but essentially it's gaming at a problematic level that does not rise to the level of a disorder. Now, how these conditions are classified is important and may carry particular weight in different jurisdictions. So, for example, in France, the government requires addiction treatment centers to provide care for people with behavioral addictions. So, if a disorder is classified as a behavioral addiction, like gambling and gaming disorder are, it may have implications for how clinical care is provided, and that may extend into training of clinicians as well. So thus, while it's helpful to have compulsive sexual behavior disorder in the ICD-11, perhaps it, uh, it would have different implications had it been classified as an addictive disorder. Now, there's a wide range of behaviors um, uh, that is conducted on the internet. Um, Gambling, gaming, pornography use being some, but also social media and shopping and buying, which are not necessarily the focus of disorders in the ICD-11. However, some of these behaviors have become particularly within the public spotlight. So, for example, the U.S. Surgeon General has put out an advisory back in 2023 about relationships between social media use and youth mental health. Uh, this may be particularly relevant for females, as when we did a meta-analysis across over 30 different countries of internet gaming disorder, internet addiction, and social media addiction, we found a male predominance for internet gaming disorder and a female predominance for problematic usage of social media. And more recently, the U.S. Surgeon General had an opinion piece in the New York Times saying that he believed that social media platforms should contain product warning labels akin to those on alcohol and tobacco products. So, keeping this in mind, we propose that the designation in the ICD-11 of other specified disorders due to addictive behaviors might be used to diagnose individuals with problematic use of social media, and also could be used to diagnose individuals with compulsive shopping and buying behaviors, for example. And in line with this, Zilka Muda and colleagues developed an instrument, the ACID-11, which is the assessment of criteria for specific internet use disorders that looks at online gaming, gambling, social media, shopping, buying, and pornography consumption. and is a relatively brief measure to capture ICD-11 criteria for these different behaviors. We have also reviewed the literature regarding the different interventions, but also have proposed models for internet use disorders. Um, the IPACE model, which is the interaction of person, affect, cognition, and execution, considers multiple domains relating to a person's core characteristics, the process of um, being exposed to stimuli and then engaging in behaviors, and how these behaviors over time may lead to disordered engagement. So if we break this down, the personal characteristics component of the iPace model um, has multiple domains that may influence a person's core characteristics that involve social cognitions, personality-related constructs, biopsychosocial constitution relating to genetics and life experiences, psychopathology, and then motives for engaging in behaviors. And these motives, particularly those to cope or to relieve negative mood states, have been particularly linked to problematic engagement. And then we have specified how um, the environmental context may influence individuals, leading to specific consequences at behavioral and brain levels. And we believe that the environmental context is important to consider, particularly since there may be interventions at policy and regulatory levels that warrant consideration in how people develop addictive engagement and behaviors. Then, when we thought about the central component in our 2019 update, we thought about the early versus later stages of addiction, where at early stages, some stimuli may lead to affective and cognitive responses that are under inhibitory control, leading to decisions to engage in specific ways that are more linked to gratification and pleasure, and that may influence reward expectancies and related constructs. At later stages, similar stimuli may lead to cue reactivity and craving that is under less inhibitory control, leading to more habitual engagement that is more compensatory in nature and may generate affective and cognitive biases. And we propose that certain brain regions may be linked to these different stages in a way resonating with the Everett and Robbins model, where the gold color reflects initial stages and the more ventral corticostriatal thalamocortical circuitry, and the more blue color, the more later stages, the more habitual and more dorsal striatal circuitry. Now, from a clinical perspective, we recognize that although there may be shifts from gratification to compensation from early to later stages, that these shifts are not linear in nature. There may be fluctuations that are important to consider in clinical practice. We also have recently modified the model to take into account cultural considerations, in this case, Eastern Asian cultural contexts, highlighting potential roles that may be risk factors like shame or fear of failure or the concept of face, and other protective factors that may be particularly relevant in Eastern Asian cultures. So we've also been considering how people may engage in internet use in a problematic fashion from a global perspective. We have been involved in a Lancet Psychiatry Commission report on problematic usage of the internet. Earlier this year, we communicated um, a commentary that describes the work of the group, and hopefully within the next 6 months or so, we should have the article published, which I think will provide important considerations for different jurisdictions as they move towards trying to protect the public health while still reaping the benefits of the internet and digital technologies. So, as part of a European Union Cooperation in Science and Technology, or COST initiative, we also were focused on problematic usage of the internet. This e-booklet was generated through that initiative. It can be downloaded for free at the web link at the bottom of the page. It's been translated into half a dozen or so languages. And the e-booklet covers multiple types of problematic usage of the internet, including some that I have not discussed, like cyberchondria, searching for health-related information in a um, problematic or interfering fashion, and that became more of a concern, I would argue, during the COVID-19 pandemic, as well as other aspects like cyberbullying, which, as digital technologies become integrated into youth's lives at earlier points in time, um, may be a more prominent concern now as compared to years ago. So this e-booklet contains information on the course of different types of PUI, considers co-occurring disorders, covers assessment and intervention information, and provides practical tips. And these practical tips may be particularly helpful for parents with respect to considering age-appropriate content and age-related durations with age-related introduction of material and devices in line with recommendations from groups like the American Academy of Pediatrics. The idea of balancing screen and physical activity. Importantly, I'm thinking about healthy sleep patterns with respect to limiting screen time before bedtime and not having devices in the bedroom. And then how parents can also help with respect to turning digital devices off when not in use, avoiding device use for emotional regulation. Again, thinking about the negative urgency motivations for engaging in digital technology use, creating tech-free zones and having clear and consistent rules that the parents will follow as well. I think also importantly, with navigating the digital environment with developing youth, is to have regular conversations about online activities in open, curious, and non-judgmental ways to engage with developing youth in digital technologies and show an active interest in learning about how youth are learning, are using digital technologies. And then um, eh, thinking about how best to prepare children for using the internet, to warn them about online dangers in an age-appropriate fashion, a developmental stage-appropriate fashion, to encourage youth to seek help if they're being cyberbullied, and to teach in general online ethics, manners, and safe behaviors. So we've also recently reviewed the literature with respect to behavioral addictions related to gambling, gaming, shopping and buying, use of pornography and sex, and use of social media. This was released in the February issue of the American Journal Psychiatry and focuses on the empirical support for interventions to help people with concerns in these areas. So, in conclusion, there are significant overlaps between behavioral addictions and substance use disorders. Gaps exist in our clinical understanding and options for people with behavioral addictions versus those with substance use disorders. Particularly, no medications have FDA indications for behavioral addictions. And we should continue to gather information, particularly within a rapidly changing digital technology environment space, where AI, for example, has been growing rapidly in ways that many people did not predict would happen so soon. We should gather more information to help address existing gaps and try to help people with concerns and to prevent problems along the way. So I'd like to thank a large number of individuals, funding agencies, and thank you for your attention. And I'm happy to take questions.